Okay, chapter 2 is going to cover the characteristics of cardiac muscle cells. And what I want you to sort of understand from this section is that there's different components to the heart muscle. And you got to make sure you separate them out into two components. One is electrical, and the other one is the actual myocardial cell. Okay? And the reason that's important to begin to separate those two out is because there's differences on the surface of those cells. Okay? They have different kinds of receptors on both of those, and they have different functions. Okay? The electrical component of the heart basically is there to propagate electrical activity rapidly to the surrounding muscle and cause a contraction that occurs together. Okay? And it tries to maintain a rhythm that's normal. Okay? The muscle cells, on the other hand, they're not really there to really, besides passing on electrical activity, which they do, but their really primary job is to contract and to basically push the blood along. You can actually have a totally normal conduction system in place, and the patient can be very, very dead because the muscles themselves do not contract. So, and that's called EMD, which is electromechanical dissociation, or what you call PEAs, which you guys are now calling it. Okay? So I'm an old timer. Okay? The unique properties of the cardiac muscle cells is that they can generate their own action potentials, and the action potential can be conducted from cell to cell, versus muscle cells and the skeletal muscle doesn't do that. They actually have to be activated by direct neurotransmitter release. Cardiac muscle, on the other hand, doesn't need to do that. Okay? If you take the heart out of somebody's chest, and we do this all the time when we do transplants and put it into somebody else's body, that person's not working on that other person's SA node most of the time. Okay? And the newer ones they're just generated by their own SA node, but basically the sympathetics and parasympathetics are disconnected from that heart. So that person's heart is generating its own electrical activity completely independent of that other person's, that new transplanted individual's neural input. And that's important. If you didn't, you'd have to put a pacemaker in all these people, which you don't necessarily have to do. Okay? So the heart does contract all by itself. When I was a young man, one of the things that I became interested in medicine was we used to take care of frogs when they were alive, and before the days of, way you do things nowadays. But we would actually put the frogs to sleep, and then we would open up their chest and look at their heart pumping. And then we would extract the heart out, and then put it into a petri dish and put it with electrolyte solution covering it, and then we would see the heart will continue to pump. Even if the heart were to stop, all you would take to restart the heart would just be to tap it with a set of tweezers, and you'd see the heart begin to contract again. So it was pretty evident that the heart really didn't need any kind of neural stimulation. As long as it had enough nutrient flow and enough oxygen delivered to it, the heart was very happy to continue to contract outside of the body completely by itself. Okay? And that happens to us as well. Okay? When you see the actual, what makes this, it's a sort of a brief review of what we talked in cellular physiology, is that this requires membrane potential energy. Okay? You have to have a negative membrane potential to be able to generate this. So that means you have to have a lipid bilayer, and you also have your friend, the sodium-potassium ATP pump, okay, to establish that gradient. And then the three essential ions that are responsible for membrane potential are going to be sodium, calcium, and potassium. Okay? The pacemaker cells themselves only have slow sodium channels, slow calcium channels, and potassium channels. The actual myocardial cells, which are the ventricular cells, on the other hand, do not have the slow sodium channels, but have the rapid, fast sodium channels, and they have calcium channels as well as potassium channels. The important difference of that is that different receptors of that fast and slow sodium channels have different receptiveness to agents that are exposed to it. So if you have local anesthetics which bind to fast sodium channels, it tends to affect the ventricular cells much more so than the conduction cells. That's why we use lidocaine to stop ventricular ectopy. Ventricular ectopy is not a conductance problem inside the conductance vessels. It's a problem with the cardiac cells are causing the propagation of electrical activity prematurely. So by giving a fast sodium channel blocker like lidocaine, you suppress the ventricular muscle cells from doing this, and you stop seeing that activity of PVCs. Okay? Now, these three essential membrane components are set up differently in the pacemaker cells in comparison to the muscle cells. The pacemaker cells, their only job is to generate electrical activity. Okay? The muscle cells are there to generate contraction force. So your basement resting membrane potential for your conductant vessels only has to be at minus 60, even to minus 65, versus the muscle cells have to be at a much greater negative potential, around minus 75 to minus 80, because that way they can do more effective work. Now these channels, what actually controls these sodium, potassium, and calcium are specific channels. These channels have their own specific function. They have different activity based. Some of them are based on voltage-gated theories. Others are actually based on neurotransmitter release and activation, such as beta-1 activation. But these proteins actually span the whole membrane, which means that they are what kind of channels? They're protein membrane channels. So that means that they're ionic channels. They actually have to have a hole that connects the inside and the outside world in the cell, okay, which allows the electrolyte transfer to take place. Okay? They are very ion-specific. You can make sodium channels very easily ion-specific because it's one of the smallest electrolytes. So making sodium channels is a very efficient way of basically preventing potassium or calcium, which are much bigger channels, from going across. So the sodium channels are ubiquitous in many systems in your cells because they have that specificity. Okay? They exist in different configurations. They usually live in open or closed or in an inactivated state. They usually don't stay in between. Okay? They usually stay either open or closed. How long it depends on many factors, including voltage levels. Sometimes they're time dependent. So there's different reasons for why they stay open. The voltage-gated channels, like the slow sodium channels as well as the slow calcium channels, depend on the membrane voltage. Okay, once a voltage is reached, the channel opens rapidly, and then it stays open depending on several factors. It could be from voltage, it closes back down, or it could be time dependent. Okay? The other things that can actually change these channels from opening will be actually the neurotransmitters themselves can actually change the permeability of these things. Cardiac cell potentials, action potentials are different in different portions of the heart, which is what I was talking about. Pacemaker cells and cardiac muscle cells are definitely different, and they're going to generate different kinds of electrical patterns. This one here shows you two of them that you're going to see. There's actually three here, but there's two of the major ones. This one here, and this one here are both muscle cells. The one here is a pacemaker cell. Notice the big difference. Okay? In the top blue circle and the bottom blue circle, both those are ventricular cells, and those are both have plateau phases, which are called phase 2s. Okay? The other thing that you see is that you see a phase 0 that has a very rapid upstroke in both of them with a over upstroke called the phase 1. Okay? Versus in pacemaker cells, you only see phase 0, and you do not see a phase 2 or a phase 1. It goes directly into phase 3. Okay? The other difference between these two is that pacemaker cells have a potential energy of usually the minus 60, minus 65. They don't really have to generate a lot of energy. All their job is to send an electrical propagation signal down and then basically send electrical energy to the surrounding cells. Okay? Now, the way it does this is it has three receptors that are available. There's the slow sodium channel, the slow calcium channel, and the potassium channel. What's ubiquitous in all these cell types is the fast potassium channels are there to repolarize the cell. In other words, drive it back down to its negative potential state. For the pacemaker cells, the slow sodium channels open slowly and allow sodium to leak into the cell, making the base, instead of being flat, like it's supposed to be, like you see the ventricle cells, how they're flat, this one begins to rise. As it rises, it eventually reaches threshold. Okay? And when it reaches threshold, then the voltage-gated dependent calcium channels open. Okay? So when the sodium channels then open, and also opening, but now they open up more fully, and so does the calcium channels, then the cell interiorly becomes greatly positive. Okay? At that point, the calcium gate closes, as well as the sodium gate closes, and the next thing that happens is the potassium gate opens, and it allows potassium to come out of the cell very rapidly, and it makes it negative inside here, driving it back down in phase 3. Okay? That's all it is. Okay, so it's three ions, 3 channels are responsible for this. Okay? The reason it's important for you to understand this is when we talk about antiarrhythmics later on, I'm going to match this up to this so it makes it all sort of work together as a consortium, so you understand it, not just memorize it, which is what I'm trying to get you to avoid to do. The muscle cells, on the other hand, they have a very nice system that they have in place, which is they use fast sodium channels. Okay, they do not have a slow sodium channel because otherwise the actual basement resting membrane potential would actually rise, which it doesn't. Okay, for the ventricular cells and atrial cells that are contracting, they have a steady resting membrane potential, which is phase 4. Okay, right here. Phase 4 has a nice steady state. Okay? What happens is the electrical activity from the pacemaker cells come by, and it causes the voltage gate to spike inside the myocardial cell. And when it spikes, it causes this little spike activity inside here. And when it hits threshold, the sodium channels open all at the same time. Okay, now sodium pours into the cell. Okay? Once the sodium pours into the cell, it causes the cell to greatly increase their electrical potential to positive. Now what's really cool about it is that you have 2 things that happen. Okay? At this point, which is the next green hump, is that your calcium pours in through the sarcoplastic reticulum inside the cell, and you also have another calcium channel that's on the outer surface of the cell that opens, that allows extracellular calcium to pour into the cell as well. Both the calciums that are both SR and outside the cell then bind to the troponin matrix and then allow the contraction to begin. Okay? Without that, then you don't get good contractility. If you get drops in ionized calcium levels outside the cell, contractility drops. Okay? If you lose calcium inside the SR eventually to depletion, then your contractility also drops off. Okay? So ionized calcium is one of those critical elements that is really required for contraction. Okay, what repolarizes the cell, what maintains the basement membrane, the phase 2 steady, is at the same time that calcium's coming in, potassium channels begin to leak out, and potassium leaks out at a steady rate. So eventually the amount of calcium coming in and potassium going out is equal, which is why you get a plateau phase. If you think about it this way, if you just let potassium stay in the cell and just let the calcium keep pouring in, what would happen is the cell would continue to be much, much more positive, which is bad because then to get it back down to resting membrane would be hard. Okay, so potassium is already beginning to leak out during this phase. And then after a certain amount of duration, the longer the duration, guess what happens to contraction? The more vigorous it is. So the longer your plateau phase, the more vigorous the contraction. Look at this example. Which one's the stronger contraction? The top one, and that's the ventricle, versus the atrium, which is narrow, okay, is a lower contractility velocity, okay, which is, again, demonstrating to you electrically there is a difference. The longer the plateau phase, the more contraction you'll squeeze out of that muscle. Okay? Pacemakers are basically in phase 4, are not flat. They also call the diastolic depolarization or pacemaker potential. The unstable resting potential is good because what it does is it progressively allows the cell to become more permeable. This is done by permeability of sodium, which is the slow sodium channels are doing this, and also due to increased permeability of calcium. So you have both of them taking place. By far the most important of one of these is the slow sodium channel. The slow sodium channel is really the one that's responsible for most of the phase 4 coming to threshold. Once you hit threshold, okay, then the voltage-gated calcium channels open, and it allows an inward movement of calcium, and then you get there's no fast sodium channels in pacemaker cells. Make sure you know that. There's only 3 kinds of channels in each one of these kind of cells. The pacemaker cells do not have fast sodium channels. Because of that, you don't get into a phase 1 too much. You get a much lower amplitude overshoot. So it's not really evident that you can pick it up, not like you would in a ventricular cell. Phase 2 is no plateau because you have no lack of slow sodium channels being present at that point as being open, but also there's no calcium channels also staying open like this, like you would in the normal ventricular cells. There is no SR component in the actual pacemaker cells. In a phase 3, repolarization is due to potassium, which is something consistent. If that's one thing that is consistent in every single cell in your body, is that potassium is by far the most important for reuptake. Yes? It has them at the beginning, but at that point it's closed. So they're closed at that point. So they're not adding to the plateau phase is what they're trying to tell you here. The book is very confusing about this in this respect, which I think is partly because of poor writing. Okay? But what they're trying to explain to you is that during this phase, the slow sodium channels are closed. Okay? And there's really no long-acting calcium that's coming in because the pacemaker cells don't have SRs that have calcium in them. Okay? And the slow calcium channels is not really using an SR component. It's using all the extracellular calcium to bring that in. That's what's driving it, reaction. So it's not as vigorous. You don't get that plateau phase with this. Okay? So here's what you do. You have this constant sodium leakage and some degree of calcium leakage. By far the most important one that causes the phase 4 to leak is sodium leakage. Now what's really interesting is that sodium leakage can be altered. You can change the velocity of the sodium leakage. If I make the sodium leakage occur faster, then guess what happens to your heart rate? It reaches threshold more rapidly. So things like sympathetics actually increase the sodium leakage. Parasympathetics, on the other hand, slow the amount of sodium leakage, and then as a consequence, this curve flattens out. And to hit threshold takes you a longer time, which slows your heart rate down. And that's really how your heart rate is regulated. It's basically how fast the sodium is leaking in and out to cause it to reach the threshold stimulus. Does that make sense? Here's how I want you to think about it. Okay? Just think of that you have a wall here. Okay? And on this wall you have 3 kinds of receptors. 3 kinds of protein channels. Okay, we have potassium, calcium, and then this guy's our sodium. Okay? This guy initially is open, which is letting sodium in slowly, okay, which is driving this up here. This is actually linked with your beta 1 receptor. Okay? It's also linked indirectly as well to your acetylcholine receptor. Okay? Because if I imagine this, okay, what's an acetylcholine receptor? What kind of channel is it? Potassium, calcium, or sodium channel? Right. Okay. If you look at an acetylcholine channel, here it is. It's got 2 receptors on it. That's where the acetylcholine binds to. Once it binds to, it causes sodium to influx in. Right? Okay? So if that were to occur, then the heart rate should increase. But in the heart, what ends up happening is it actually blocks it. Okay? By adding acetylcholine, it actually slows it down. Okay? So it's just kind of different than other receptors in your body. Okay? But in this case, the acetylcholine goes in there and slows it down, and when you increase parasympathetic tone, the actual heart rate begins to slow down. It closes it up. One of the few examples where it does the reverse what you expect. Okay? The sympathetic tone, on the other hand, because it's linked via the beta receptor, will actually cause the sodium to leak in more rapidly and cause it to hit threshold more rapidly here, and then the heart rate increases. So that's what you're doing to change your heart rate, sodium leakage rates. Cardiac muscle cells, on the other hand, have fast response action potential, and they have this rapid, fast sodium channels during their initial portion. And the answer is why? Okay? Because you want to have it reach the plateau right away so contraction can take place. The longer it takes to reach that plateau, the more energy is dissipated as waste. So you want to hit that plateau as fast as you can. So the fast sodium channels are critical for that in that phase 0, where you get that rapid spiking upstroke where you get to plateau phase very quickly. Okay? There's different medications that we can give where you can actually suppress that and get that almost to go to 0, and you can actually affect contractility. The rapid phase 0 will overshoot into phase 1, okay? And you get eventual closure of the fast sodium channels. The rapid reversal of overshoot is due to sodium closure, and then the potassium channels will open, as well as the voltage-gated calcium channels will form, which is this one right here. Okay, that's your calcium channels opening, okay, which is then allows for the phase 2 plateau to develop. This is due to the the voltage-gated calcium channels opening, as well as the sarcoplasmic reticulum calcium influxing into the cytosol of the cardiac muscle cell. Eventually, what you end up happening is the actual calcium channels close down in both the SR and the cell wall membrane, and then potassium takes over and it causes phase 3, which is repolarization, to take place, and you go back to its nice, stable, flat phase 4. Okay? Any questions about that? Okay, what's important about cardiac conduction cells is it goes from cell to cell. Cardiac cells are connected via intercalated disc. Conduction velocity speeds, which in action potential propagates through the region of the heart, is directly correlated to the diameter of the myocardial cell. Smaller diameter slows down conductions, which means there's less surface area. It's directly dependent on the intensity of the local depolarizing currents, and it's also dependent on the variation in gap junctions. Most of the time we have a lot of gap junctions in the heart, so the actual cardiac potential goes very, very rapidly through the heart. Okay, the action potential moves through the heart as an electrical component, which we call the SA node. As it propagates in electrical activity, it generates a P wave. Then it causes the PR interval, which is the AV node. And then the His-Purkinje fiber cells are actually responsible for the QRS. The actual T wave is a repolarization component, which is the cells are doing it by themselves. This is when the potassium is refluxing back. So which one is going to indicate hypo or hyperkalemia? And the answer is the T wave. Okay, and the T wave is really when repolarization is taking place. So that's where you're going to see the T wave changes. If you see spikes in T wave, that's hyperkalemia. In other words, you see a T wave becomes very large. If you see the T wave becoming flat, it becomes hypokalemia. It's something you can pick out very quickly in EKG, as well as your telemetry monitoring if somebody's having that. As for the ischemia, what you see for the ventricle is in the ST segment. ST segment depression or elevation are very important differences. ST segment depression is ischemia. ST segment elevation is infarct. Okay, so if you see somebody tombstoning, which is what this is a tombstone sign. RIP. Rest in peace. You don't want to see that, okay? That's the tombstone sign. That's why it's called a tombstone. If you see that, that person's infarcting. You don't want to see that. This is what you see in the operating room, okay? ST segment depression, that means a person is ischemic and you got to do something now. It's not the time to sort of mess around and wait. Let's see if it gets any better. No, this is the time to start giving morphine, oxygen. Make sure that the person's adequately being perfused. Make sure the pressure is adequate. You're going to start doing different things to make sure that the heart is doing okay. So, in Chapter 4, we're going to talk about the major electrographs. So we're going to expect you to know telemetry, the major components of the P wave, QRS, and T wave, which we'll talk about in more detail in Chapter 4. Okay, this is where I'm going to stop for 10 minutes, and we'll start back up, and then we'll go for 30 more, and then we'll stop. So at 10:30, we'll start again. Unless you want me to continue and just finish up. You want me to just finish up at 10:50, 10:45? Okay, I'll just stop at 10:45, okay? Okay, control of the heart beating rate are the intrinsic levels, okay? The heart can work by itself without anything, without any additional assistance, but it is altered by the sympathetics and parasympathetics. So the autonomics are very important at the SA node. The parasympathetics will actually affect the SA node and the AV node, and they slow down the heart rate by making the phase 4 flatter. Acetylcholine actually increases the permeability to potassium and decreases the permeability of sodium. So that's by far, which is kind of strange when you think about it in the sense that the acetylcholine normally would open up a sodium channel, but in this case actually acts by binding to that sodium channel and inhibiting it. Because it's not what kind of channel is it? Think about this. It is not a fast sodium channel. It's a slow sodium channel. See how the difference is? It would be bad if you had parasympathetics involved with the ventricle, because the ventricle has what kind of channels in it? Fast sodium channels, okay? So if you had the parasympathetics in there, you might have bad effects. Anyway, so you see the vagus nerve is actually a cranial nerve number 10. Eventually gets out via the postganglionic receptor binding to acetylcholine as its major neurotransmitter, but that actually affects the slow sodium channels by decreasing sodium permeability and increasing potassium permeability, which keeps the charge more negative and makes the resting membrane potential phase 4 more flat, eventually decreasing heart rate. It also affects the AV node via the same similar fashion and decreases conductance velocity through it. So that overall, it decreases heart rate, and it also decreases atrial kick factor as well. Sympathetics, on the other hand, it works on the beta-1 receptor. Beta-1 receptors are secondary G-coupled proteins, which act on these slow-acting sodium channels by opening them more rapidly, okay? And that generates a much more increase in slope velocity on your phase 4, increasing heart rate. Norepinephrine, which is the final end product of the sympathetic discharge, is also affecting the contractility of the heart by increasing contractile velocity as well, the ventricle as well as the SA, as well as the atrial cells. So sympathetics increase heart rate. Norepinephrine is a major culprit here, increases permeability to both sodium and calcium. It makes the phase 4 elevated reaching threshold more rapidly. It increases chronotropy and increases dromotropy by altering the conduction velocity. Cardiac muscle contraction. Cardiac myocytes are striated muscles mechanically connected by intercalated discs, and they basically work as a syncytium. The myosin and actin are the major building blocks of contraction, just like we talked about before. It comes back to the same concept. The important concept here as well is that the tropomyosin and troponin complex is where the calcium binds to. Okay? By causing this binding, it moves itself out of the way, which then allows the myosin head to basically bind to the actin and cause a ratcheting effect for contraction. So here's what you're looking at. Okay? This is essentially this initial study that we demonstrated about an hour ago when we talked about the individual sarcomere. This is what they worked on. Okay? And what they're looking at here is how much binding there is on the myosin to the actin elements. The actin actually has a tropomyosin complex surrounding it that prevents the myosin head from binding. Okay? When you look at this picture, you can see that this little blue strand here, okay, that's around the green strand, is preventing the myosin from binding. Okay? When calcium binds to this tropomyosin complex up here, it causes a configurational change of this protein. It ratchets it and shifts it out of the way. When it shifts it out of the way, now the myosin head can bind to it, and as soon as myosin head binds, it's already loaded, it fires, causes contraction. So what initiates contraction is not ATP. What initiates contraction is calcium. Calcium. Okay? So once the calcium binds, that's when the contraction begins. Okay? Once the myosin head binds, the contractile element that does do the work is the myosin head. So it pulls. Okay? And when it pulls the actin with it. Okay? Now at that point, the muscle is contracted. And it can't do anything. Okay? So what actually will cause the muscle to relax is the next element, okay? Which is ATP. ATP is needed by formation of oxygen to basically oxidative phosphorylation to produce the ATP. So if the person becomes ischemic, it's not that they stop contracting, it's that they can't relax. So the muscle gets stiff, okay, and it can't relax and reload itself. Okay, so what happens is the ATP binds to the myosin head, and it breaks the bond between the actin and myosin, okay, which allows the actin to re-expand back to its normal state. Okay? At the same time that's doing that, the ratchet, which is the myosin, recontracts back to its activated mode. If calcium is still around, what will happen? Grabs again and pulls again. Okay? So contraction continues as long as calcium is there. Okay? So so what begins contraction is calcium, and what ends contraction is dissipation of calcium. Okay? It's both. End and beginning is calcium related. But what allows the myosin to break off and for the heart to relax properly is ATP driven. Okay? Make sure you understand the difference. Now, if you see somebody, and I wish people would explain this better like I just explained it to you guys, because if you did that when you got to clinicals and you saw somebody's heart and you saw that the ventricle was not relaxing, the first thing your mind should be, oh my goodness, they're not getting enough oxygen to them. The tissue is ischemic. It's not because calcium is the issue, it's because the ischemic tissue is no longer getting ATP produced to it, so the heart can't relax. So what you get in that situation is what's called diastolic dysfunction. During diastole, when you get relaxation to take place, it's not taking place. Okay, so you really need that. Okay? What the atrial kick will happen when you do that is a kick will generate a higher pressure than expected, and you'll see that your PA occlusion pressure rises in that kind of situation. And it's not because you have more volume in the ventricle, it's just that the ventricle can't relax. So when the atrial kick occurs, it's pushing against a very stiff ventricle. The key to this is sarcoplasmic reticulum is what holds calcium. Okay? Without the SR being healthy, calcium is not reuptaken properly at the rapid rate, and it's not conserved adequately. So SR is very important for cardiac muscle function. Okay? The other thing that's important is ionized calcium levels are critical because they replete around 20% of calcium that is basically lost. So you have to maintain an ionized calcium level in your bloodstream so that the body has a way to replenish some of this wasted calcium that it does consume. Okay? The other thing that's important for you to understand is that the SR, if you begin to release too much calcium for too long a period of time, you do end up burning up the heart. Okay? The mechanical device can get burned up if you get too much exposure, which is why you see when somebody gets very high levels of epinephrine and norepinephrine for chronic periods of time, the heart ventricle just becomes mush, okay? Because it becomes depleted of ATP. It's something you don't want to do. Because what does it take to get calcium back into the cells? Back into the SR. It requires energy. You're pushing it against a gradient. So you're requiring lots of ATP to do that. So this calcium reuptake is not a joke. It requires a lot of energy. Okay? That's why it's going down a gradient. Okay? When the muscle depolarizes, calcium pours into it, which is going down a gradient. But then it's repumped back into the SR using ATP to do it. Okay? If you look at myocardial cells, they're covered in mitochondria because they're requiring a lot of ATP to do the work. That's why they extract up to 60 to 70% of the oxygen that's delivered to it, because the mitochondria use it to convert it into oxidative phosphorylation to produce ATP. Okay? The excitation-contraction coupling, the idea is the T-tubules basically allow the electrical activity to go propagate itself down very close to the SR, which then causes the voltage gate of calcium channels to open and allow calcium to leave the actual sarcoplasmic reticulum. The way I want you to think of it is that the sodium channels, in a sense, act like captains. Okay? When they come into a cell and depolarize, they go to the actual Quonset hut where all the troops are at, which is the calcium, and they tell them, hey, come on out here and we'll do your work. Okay? So they come on out. They cause contraction to take place. And then when the sodium channels go away, which is the captains go away, then the troops go back into the Quonset hut, leaving the cells to stop contracting. Okay, so it's an analogy. Okay, without ATP, you prevent the breakdown of calcium binding, resulting in lack of relaxation. So eventually, if we do that, we see in skeletal muscle, you get similar effects, which we call rigor mortis. Okay, rigor mortis is very similar in the same respect. You have a depletion of ATP in that kind of state. 80% of reuptake of calcium is into the SR, 20% is extruded into the extracellular fluid, which means that what happens? That means you're losing 20%. That means it's going to come from somewhere. And that's going to come from the extracellular space, which is from the intravascular space eventually. So that's why you have to maintain ionized calcium levels adequately. Otherwise, you do deplete it over time. So the cardiac muscle mechanics that you're looking at is isovolumetric contraction. There's no change in length, only increase in tension. This is a preload. This is what you want. You want that. Let me go back a picture and see if I got it. No, let me go back. Okay. See these guys here? Okay. The blue is the actin, and the orange, like brown color, is the myosin. Okay. What I want you to think of it is, imagine that the myosin is a rowboat or a sculling boat, which means that you have a bunch of people sitting inside the sculling boat. You've got 1, 2, 3, 4 on the side. You got 1, 2, 3, 4 on the side. Okay, and they have oars in the water. Okay, does that make sense so far? That's the myosin heads. The oars are the myosin heads. Okay, if you want the full contraction to take place, you want to have all 4 oars in the water at the same time and then all pulling together. That gives you the best contraction. Okay? If I only have 2 of them, that means I get a 50% contractile force. And imagine this. Okay? If you take the actin and underload it, which means I take the actual oars, okay, and now I put the oars in this way. They're basically parallel to each individual, which means I take this component here. Okay, now I'm moving it to here. What happens to my oars? Can they do any work? Can't do anything. So underloading it, or low preload state, means that nothing can happen. That's why if you have an empty heart, the patient's very dead. Okay, because the ventricle cannot contract. As I begin to load it with more volume, okay, which is what preload is, as I begin to increase the amount of volume, the actual sarcomere, the actin, begins to separate out, and there's more oars available to put in the water. Okay? And the optimum range would be where, this is drawn like this right now, where you have basically 4 oars in the water. Now you're going to get the best contraction. But let's say now I over-distend it. Let's say I pull it apart even more. Okay? As I pull it apart, I'm now here. So now instead of having 4 oars in the water, I only have now 1 oar that can do the work. And that's called failure. Okay, at that point you can't put any more. If you distend that heart anymore, the sarcomere, what will happen? You'll have no more contraction. There'll be no oars in the water anymore. Okay? So you have to maintain a certain amount of preload. That's what you optimum. You want to be always with 4 oars all the time. That's optimal. You don't want to be over or under. Does that give you a good analogy? Did that work for you or no? It's a hard concept to explain to people. Anyways. So what it generates is this curve. This curve here is a preload curve. This is telling you how far that distance is. If you stay between here and here, you're basically keeping about 4 oars in the water. Once you get into this area, now the sarcomere is too tight and you can't get any contraction out of it. And then if you're over the top here, then you're back to the mode that I was telling you where you're down to 1 oar and you can't really effectively contract. You're over-distended. Okay? Now this preload curve is dependent on the compliance of the ventricle. And it's a bigger concept, which is you're going now from the sarcomere, now you're working with many different sarcomeres. Okay? And the more sarcomeres there are, the stiffer it is. Just think about it. If you think of a rubber band, okay, analogy, if you take a thin rubber band, as you try to expand a thin rubber band, it easily gives. Okay, so that preload curve becomes very flat for that situation. If you're looking at it from the standpoint of the right ventricle, great. I won't erase. Okay. If you look at the right ventricle, the preload curve for that guy is much more flat because there's less sarcomeres. But if I look at the left ventricle, the actual mass of the volume of sarcomeres increases dramatically, and then that curve actually becomes more upwards. The reason that's important for you clinically is that you want something to change with volume changes inside the ventricle. So that's why we use a PA catheter. PA catheters are much more efficient at telling us that the volume changes with pressure changes. It's a linear correlation. Versus a right ventricle, which is thin, as you increase the volume, the pressure changes very little until you get into the failure portion of the curve, and that point is too late. So that's why you're told, don't really use a CVP, you really should be using the PA occlusion pressure. Both those things are measuring preload, just that one is more accurate because of a difference in the compliance curve of this. The other thing that's important to understand too when we talk about valvular dysfunction is that the ventricle, when it hypertrophies, like in aortic stenosis, the preload curve will jump up like this, and then later on, in a chronic state where it begins to dilate, it shifts into this. And knowing that will tell you if it's an acute situation or versus a chronic valvular condition, which kind of you can pick it out as well, which we'll show you that later on. Okay. Cardiac muscle contractility is measured by the contractility point, which I described previously, so I'm going to skip that, okay, which is the aortic valvular closure point, which is here. This is the contractility line that's being generated. An increase in contractility basically generates a new line that goes this way. A decrease in contractility will generate a line that goes this way. Okay. A decrease in contractility would cause a decrease in stroke volume. An increase in contractility, on the other hand, would increase the stroke volume. How do you describe the cardiac muscular function? You always have to go back to it. Anybody asks you this about the cardiac muscle, heart rate, preload, afterload, and contractility. You've got to understand these different components. Preload is the sarcomere length prior to contraction. Okay? That's how many oars you have in the water. Okay? If you have the sarcomere length adequate, which is usually around 2.2 microns, that's the perfect mid-distance. Okay? Pressure volume curve basically mimics this by telling you which portion of the Starling's curve you're on. This is measured indirectly as left ventricular end diastolic volume. Unfortunately, this cannot be measured except for you have an echo, okay, which is sometimes very difficult to do. Instead, we measure it indirectly via left ventricular end diastolic pressure, which we then measure out as being PA occlusion pressure. Okay? Now, we use this as a better model because of the correlation of the compliance, which is much more linear in the left ventricle comparison to the right. As to afterload, that's a very difficult concept for most students to understand, again, because it is a complex concept. It is not just peripheral vascular resistance. It is also has to do with the aortic valve function, how tight the aortic valve is. It also is dependent on the intercavitary pressures differences, wall thickness, sarcomere length, chamber radius, geometry of the ventricle. So it's something that's very difficult to measure. We sometimes use SVR, but that's grossly not a normal value you should use. The reason it's not, it'll only be used as a trend, but it does not indicate to you true afterload. Okay? The other thing that's a problem with SVR, it's a calculated number. And the way you know that all resistances is just imagine this. That's okay. How do you measure vascular resistance? I got it. I don't know why the eraser don't work. Resistance is measured as equal to perfusion pressure over cardiac output. Okay? So if you're looking at SVR, your perfusion pressure is mean arterial pressure minus your CVP over your cardiac output. If you're looking at pulmonary vascular resistance, then that's going to be your PA pressure, which is mean, minus PA occlusion pressure over your cardiac output. Okay? So you don't have to memorize it. Just know the concept. Delta P over cardiac output. And that's the resistance. Okay? Contractility, on the other hand, can be measured, but when you measure it, you can usually use a cardiac output, but please make sure that you look at not the cardiac output, but you look at the stroke volume. Stroke volume is an indicator of contractility. Okay? If your stroke volume is increasing, contractility is a lot of times increasing. Okay? Contractility can also be assessed via echo, which is really useful, and as well indirectly by stroke volume. Heart rate, of course, can be monitored many different ways. Pulse oximetry is very nice because it tells you which one is pulsatile component versus EKG. You can have somebody in bigeminy with non-pulsatile bigeminy, which means that every other beat is really not true. It's not causing effective contraction. So pulse oximetry will pick that up and tell you. Make sure your rhythm is adequate and make sure that you have enough time for adequate cardiac filling. Now, other ways that you're going to look at the heart over time is we're going to make you think of it as electrical activity. We also want you to think of it as hard as a pump. So you need to look at pressure changes, volume changes, things that generate force. Okay? The heart also generates sound, which causes murmurs to occur. So you have to know when that occurs in different kinds of murmurs. Generates heat as well. Electrical activity over time is also a critical component. Why we're going to go into chapter 4 and basically talk about that as well. Pressure over time curves are something that we use over and over again. Okay? And unfortunately, people don't understand what they're really looking at. They just begin to accept that this is the normal curve. But there's a lot of information that you can glean from looking at a pressure over time curve. A pressure over time curve correlates with a pressure over volume curve. Okay? There's a direct correlation in which time sequence on that pressure over volume curve occurs due to this. So let's look at this. If you did a pressure over volume curve, that's your normal. This is mitral valve opening, mitral valve closure, aortic valve opening, and the aortic valve closure. When you look at your pressure over time curve, this is going in this direction. Okay? Mitral valve opening, okay, is here, and that's your diastole. And then this is from here to here. Okay? Here, this point here is this is where valve closure. This is where diastole really begins. Okay? That's why that line starts here. Okay, you see that's not where the mitral valve opens. Diastole starts at the aortic valve closure point. That's really when diastole begins. Okay? Systole occurs right when the mitral valve closes, and that occurs right here. So if you were to take a pressure monitor right there, that's really an indication to you when diastole is. So if you're going to say of your PA waveform, which one is it that actually measures the volume at a certain specific point in time, it's right before the C wave is really an indicator to you of preload. That's the actual measurement that you want to do. When you're doing a CVP or a PA occlusion pressure, the preload point is right before the C wave. That's when the ventricle is its most full state. Yes? Sorry, you lost me. What?
On the top, on the printed picture,
Oh.
says
Yep. Sorry, aortic valve closure. That's the diastole. This is aortic valve closure point. I must have been speaking too fast. Yes, I must have been speaking too fast. Sorry. Sometimes I do speak fast and I do jumble the words sometimes, but that's the aortic valve closure point. And that's when diastole ends. That's when diastole begins and systole ends. Okay? So aortic valve closure point. Okay? Which then correlates to this right here. This here correlates to that. Okay? Your systole occurs, this is isovolumetric contraction. That correlates with this here. Okay? This doesn't look like it's isovolumetric because this is not a measurement of volume. This is a measurement of pressure change over time. Okay, so you're not going to see a vertical line going upwards in this case. Okay? Eventually you reach the aortic valve opening point. So this actually indirectly is the measurement of afterload. Okay? That's your afterload point that we get you to sort of figure out, and we'll go over and over again and we start drawing this stuff out. So what I'm trying to show you here is not to get into the specifics just yet, but you're going to get into this more in time, that you begin to, especially next semester when we talk about pathophysiology and do the cardiac workbooks, is that I want you to understand that these waveforms are generated as a consequence of alterations in preload, afterload, and contractility. Okay? Again, this is something you are going to have to know for the test. I expect you to know the different waveforms. The bottom one that's a dashed line down here is your PA waveform. That's your A, C, and B. A stands for atrial contraction, C for the mitral valve cusp closure. V wave is for ventricular contraction phase. Okay? The actual ventricular waveform is the solid line. Okay? The solid line has the atrial component, the atrial kick portion of it in it. And then this is the the ventricular waveform. Okay? And then the top one, this is other dashed line up here, is the arterial waveform. Okay, and the arterial waveform has got the dichrotic notch in it. The dichrotic notch indicates to you the point of valvular closure. Okay. Most monitoring uses some parameter over time, and you will need to extract the information so you can monitor, can give you the most information available. Okay. This takes time to learn, and you need to start doing the models first in class. If you don't do the time now, when you get to clinical, you're going to get lost. People are going to tell you about certain things, you're going to go, I don't see what they're saying. And it's going to be very difficult for you to catch up. So this is the time to do it when you're in class. Okay? So when you get to clinical, then you can start seeing it. And if you do that transition, it makes it very smooth. The last one, interrelating cardiac muscle mechanics and ventricular function. What I want you to sort of understand is that the whole point of all these discussions is to make you a better clinician. Okay? You really have to understand preload, afterload, contractility, and heart rate, okay, and how that affects the ventricular function.